Good afternoon, everyone, and welcome to this teleconference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Chris Payne, editor for MS Focus, and I'm joined by Dr. Ben Thrower, who will be speaking on the topic devices, gadgets, doodads that may help your walking. After the presentation, we'll open it up for your questions and comments. Now I'm delighted to introduce our speaker. Dr. Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center. He has served as the medical director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the senior medical advisor for the Multiple Sclerosis Foundation and enjoys contributing to our quarterly magazine. When Dr. Thrower isn't dressing up as the pirate Jack Sparrow, he can be found playing with his new grandson, Sam. We're pleased to have him present on this important topic today. Dr. Thrower, thank you so much for being with us, and now I'll turn it over to you.
Great, thank you, Chris, and thank you to everyone else at MS Focus. I'd like to say a congratulations to Casey Minnis and Natalie Blake as the new fearless leaders of the MS Focus. They are stepping up for Alan Segalov, who's been a wonderful leader of this organization, and I know that these two folks will carry on that great tradition of serving the MS community. I've worked with both of them over the years, and I know it's going to be wonderful. So this is, I think, kind of a fun topic. We're going to talk about walking issues, but really focus on some of the devices out there, things that we can use to help overcome any of the challenges that MS might throw at us. And we know that this is an important topic. So if that's going to advance here for me, and it is not. Can you advance it on your end, Deb or Natalie? Or Casey? It is not letting me advance.
Actually, if you give it a double click.
There we go. How about that? That's why you're here.
Absolutely.
So this was an interesting survey by NARCOMS, the North American Research Committee on MS, looking at how prevalent walking issues were in the MS community. And I think one of the important sort of slices of the pie is this one. So really it was the small minority of people with MS in this survey, only 15%, reported no walking issues whatsoever with their MS. So most people with MS, 85%, had some degree of challenge to their walking. And so there are a lot of different ways that MS could potentially affect walking. And in one of our other programs, we go into each of these individual topics as to how MS can affect walking. But what we're going to talk again today about is more some of the technical ways that we can overcome these things. But just to refresh everyone's memory, some of the ways that MS could potentially affect your walking would be through spasticity or increased muscle tone, foot drop, weakness in the ability to get your toes up off the ground, nerve fiber fatigue that typically results in exertional weakness and or heat sensitivity, sensory ataxia. This is not being able to feel position changes in your feet, and this results in walking like maybe you've had a drink too many. So feet wider apart, knowing where the walls are, just being a little bit off balance. And then cerebellar dysfunction. The cerebellum is the primitive part of our brain that doesn't coordinate sensation or strength, but controls how much we move and how well we move. So with cerebellar dysfunction, for instance, you might try to reach out and grab something, and as you get closer to it, you have more difficulty sort of reaching that target in a coordinated fashion. So when we think about spasticity, what does that look like, and what are some of the devices that might be in the toolbox to help with that? So the clinical signs of spasticity are going to be very overactive deep tendon reflexes. When we tap on your knee in the exam room, you get this really hyperactive response. Muscle spasms, clonus. So if any of you have ever experienced a bouncy leg, so you get your foot in just the right position and your leg starts bouncing up and down, that's clonus. What clonus represents is an overactive deep tendon reflex. So when we tap on your knee, we're eliciting that electrical response. We're sending a signal via the tendon to the nerve, to the spinal cord, back down to the muscle, and it makes the leg jerk. What clonus represents is that reflex arc firing over and over and over again. Typically, if you move your leg, get that joint into a different position, it's going to stop, but it can be somewhat annoying. Spasticity and spasms can be painful. They can result in impaired voluntary control of skeletal muscles. A lot of people with spasticity feel like if they're trying to walk, that maybe one of their feet is magnetically stuck to the floor. So the cartoon graphic here shows an individual who has classic spasticity. Spasticity in the leg tends to be extensor. So the leg's going to want to straighten out. So you can see his toes are pointing down to the ground. His knee is stiff. In the arms, spasticity tends to be flexor. So he's carrying his wrist in a flexed position. His fingers are flexed. His elbow is flexed. So that's what classic spasticity looks like. Flexor tone in the arm, extensor tone in the legs. So there are a lot of things that we can do for spasticity, but in terms of a device, a gadget that can potentially be used in helping manage spasticity, there is the intrathecal baclofen pump. So baclofen most commonly is used as an oral therapy in multiple sclerosis, and it definitely has a place in the management of MS taken as a pill. One of the challenges of oral baclofen is when we put baclofen into the GI tract, it gets absorbed. A certain amount of it is eliminated by the liver. It's degraded as soon as it hits the liver. So that part of the baclofen that we've just taken by mouth never gets anywhere useful. A certain amount of the baclofen crosses the blood-brain barrier and goes into the brain itself. That's not where we want baclofen working. We really want baclofen working at the spinal cord level. The part of baclofen that gets into the brain itself is where we get the sedation. That's not what we're trying to do with baclofen. We really want it, again, all at the spinal cord level. So what if you could take concentrated liquid baclofen, put it into the spinal fluid directly? You could bathe the spinal cord in concentrated liquid baclofen. You get, in theory, all the good and none of the bad, and you're using a lot lower dose. So that's what this pump is for. The pump itself is about the size of a hockey puck, a little bit thinner in thickness. Is surgically implanted under the skin on one of the flanks. And then there's a sort of a surgical tubing, very fine, that is sort of buried under the skin and delivers that concentrated liquid baclofen into the spinal fluid. So you're getting it exactly where it needs to be and only where it needs to be. Obviously, this is not usually the first thing that we're going to reach for when we're managing spasticity. We're going to frequently try stretching, physical therapy, oral medications before we go right to this, because it is a surgery. This is surgically implanted. This device will hold about 3 months worth of that concentrated liquid baclofen. The person who has this is going to go back to the managing team and get that pump refilled on about an every 3-month basis. It can be adjusted externally. So each of these pumps has a security code. The healthcare team can hold this sort of electromagnet over the device, access that code, tap in with a laptop computer, and actually see how well the pump is working, make adjustments to the dose of the pump, all through this external system. They are MRI compatible. If we put someone into an MRI scanner that has one of these pumps in place, we want to do something called interrogating the pump afterwards. That means checking the pump out with that external device to make sure it's still working the way that it should work after an MRI. Because this is a surgical procedure, we want to make sure that this pump is going to do what you want it to do before we have one of these implanted. So there is a trial sort of protocol that can be used, and that can go one of two ways. There's a temporary external pump that can be put in for about 24 hours and let the person sort of get a sense of what this baclofen in the spinal fluid is going to do for them. Or you could do a one-time dose of concentrated liquid baclofen via spinal tap to sort of simulate what that pump would do, just to see if it's really going to give you the results that you're looking for. So that's our first gadget. So foot drop. So when we think of things that affect walking and multiple sclerosis, foot drop is by far one of the most common things that we see. If you had to pick the two weakest muscles in the legs of a person with MS, it's going to be your ankle dorsiflexors, your ability to get your foot up off the ground, and your hip flexors. If your hip flexors weren't weak, you would do something called a steppage gait. So if your foot wants to drag the ground, if your hip flexors were strong, you would just bring your knee up a little bit higher so that you didn't drag your toes. The problem for most people with MS is if their ankle dorsiflexors are weak, their hip flexors are probably weak, and they can't do that steppage gait. They can't bring the knee up higher. So what they end up doing is the third bullet, circumduction. They swing the leg out and around in kind of the circular motion to clear the foot. A lot of times the person with MS is not even aware they're doing this. If a friend or family member walks behind you when you're fatigued, they'll notice it. They'll see that the unaffected leg is moving in a normal sort of plane to and fro in line with the body, while the weaker leg is going to be circling out and around. The problem with that circumduction pattern of walking is you're using muscles to walk that you weren't designed to use. You will fatigue very quickly. It also puts more stress on your knee, your hip, your lower back. It's just not a normal mechanical pattern to walk with. So we really like to be aggressive in managing foot drop. Traditionally, when we send you to the physical therapist to help with this, they're going to prescribe an ankle foot orthotic. We'll talk about this some. So ankle foot orthotics can be wonderful for some people. They can be not so wonderful for other people. They may not fit in the shoes you want them to fit in. They may be more visible than you want them to be. They limit your ability to push your foot down. If you're trying to drive a car and you're used to pushing on the gas pedal and the brake pedal, it's hard to do that in an ankle foot orthotic. So while it's a great tool, there's certainly some other things out there. So this is what a traditional ankle foot orthotic looks like. They can be hinged at the ankle also, so that they're a little more mobile. With a lot of these devices we're going to discuss, some of these things are just really a matter of trial and error. You get in there with a physical therapist or with some other member of your healthcare team, and you just got to try it out to see if it's going to do what you want it to do. I can sit in the exam room with a person with MS and say, I think this device is going to be great for you, but until we really try it out, it's hard to know for sure. So an alternative, it's a little lighter weight. You can see there's a lot less material here at the ankle. They are these toe-off devices. They're a little more flexible than a traditional ankle foot orthotic, and they may fit in the shoe a little bit more easily. So again, this is kind of a slightly slimmer, lighter weight version of the ankle foot orthotic. Couple of over-the-counter devices. So if you have a mild foot drop, maybe you just need something for walking a long distance, or you're going to Disney World and normally you wouldn't be walking this far, but it's going to be hot, you're walking for a long distance. This is an over-the-counter device called the Dorsi-Strap. Super simple, basically just a soft wrap around your ankle, laces up into your shoe. It's not going to give you any lateral support of your ankle, but it's going to help you just get those toes off the ground. Website is there. I've not checked it here in the past couple of months. They used to run about $45 or so. I imagine with inflation, they've probably gone up a little bit, but can be a nice thing to have in your toolbox. Little bit sturdier device also over the counter is the Sabo device. You can see a little sturdier wrap around the ankle. It has these little sort of fine steel cables that sort of go onto these attachments on your shoe. This knob is a tensioning knob. You can crank that up as tightly as you want. A little more sturdy than the Dorsi-Strap. These used to run about $140. Again, I've not checked in the past couple of months, and maybe a little bit more. These things are indestructible. I've seen people, hike in them for years and not wear them out. So these can be a great addition. And then there's some other ones out there. If you just Googled devices for foot drop, there are all kinds of competing devices. But I would say my favorite, if you're not gonna use something prescribed by the physical therapist, my favorite is probably this one, just because of how durable it is and affordable it is. So we get up more into the higher tech things now. So we have known for over a century and a half that if we stimulate the nerve on the outside part of your knee, that's the peroneal nerve. If you feel the outside of your knee on the side, you'll feel a little bony knob. Right around that knob is where the peroneal nerve runs. If we stimulate that nerve, your foot's going to come up. We're going to stimulate your ankle dorsiflexors. So this is one of the first devices that was designed to help stimulate the peroneal nerve and help with foot drop, the WalkAide device. I'm going to show you another device called the Bioness device here in just a second. Between the two, our therapists like the Bioness device quite a bit better. The WalkAide is great for some people. I think the WalkAide works much better in patients who have had stroke or spinal cord injury than it does in multiple sclerosis. Why is that? The WalkAide really, the physical therapist has to set certain parameters. The WalkAide device fires your peroneal nerve based upon acceleration and tilt of your knee. So when you try to take a step and your knee moves forwards, this device is set to sense that movement. That the physical therapist has to set those parameters at a set device, a set level. The problem with your foot drop is it's not set. It varies throughout the day. Any of you dealing with weakness know this. You know you have good days, bad days. You know you probably function better in the morning than you do in the afternoon. And so whereas your function is dynamic, this device is not dynamic. So it's going to work well some of the time and not so well other periods of time. So we like this one a little bit better for the MS community, the Bioness L300 GO. This is the second generation of this device. The original Bioness device had a little clip down here in your ankle that was a radio telemetry device. It sent a signal back up to the stimulator when you were trying to step. They've eliminated that, so now it's all self-contained here at the knee. This is dynamic. It reads your environment. It can adapt as you go through the day. If you're having more weakness, less weakness, it can adapt to that. There is a cuff that can go on top of this that can actually work for the knee flexors or extensors, depending upon what the need is. I would say with this device, it can be just a miracle in some individuals and not so great in other individuals. Again, it's a matter of getting in, working with an experienced team who knows how to use these things. If your physical therapist is not familiar with the Bioness device and you wanted to try it out, they can call the Bioness company itself. The Bioness folks will send out a physical therapist to work with your physical therapist to actually trial this device to see if it does what you want it to do. This is from a couple of years ago, one of our individuals. So this lady is walking with a walker with her ankle foot orthotic on. It took her to go 10 meters. It took her 90.75 seconds. So now she's still got her walker, but now she's got the Bioness device on. She cut that time in half. She's walking twice as fast. That's when we see a response with the Bioness device. These are the typical numbers that we're seeing. It really can make a big difference in how well someone's walking. It really cuts down on their energy utilization throughout the day. They're not fighting with that circumduction throughout the day. So we're big believers in this type of device. There's a new player on the scene that just got FDA, I wouldn't say approval, but it got sort of a clearance by the FDA. So there's a difference between FDA authorization and FDA clearance. FDA clearance means that they see no safety concerns. They're not really making a comment on the effectiveness of the device. This is called the neural sleeve from a company called Cionic. They did their press release just about a month ago. It's supposed to be commercially available this fall, and our physical therapists have requested that this company come out and do a demo for us so we can take a look at it. It sounds exciting. It has the nerve stimulators built into that black kind of neoprene sleeve here, and the hope is that it's going to help with foot drop, and it should be able to hit the knee flexors or extensors also. It was a small study. It was 70 individuals, and these were not all individuals with multiple sclerosis. It was a mixture of people with MS, stroke, spinal cord injury, and cerebral palsy. The results were impressive, though. There was a 143% improvement in the foot drop. So we're excited to see what this looks like in real life. Don't have any idea on the pricing on it quite yet. Hopefully insurance companies will pick this up. So we mentioned cerebellar dysfunction. Again, this is the kind of the cerebellum, that primitive back part of our brain that controls how much we move. When the cerebellum is not working right, it can have fairly significant consequences. It can affect speech. So we talk about a cerebellar speech pattern where there's a loss of sort of the normal intonation, where there's the normal up and down melodic flow to speech. And people with cerebellar dysfunction, that their speech, the highs and lows don't feel like they're in the right places, and they don't have any control over that. Just like they have difficulty controlling kind of the intonation of voice, they have difficulty controlling how much they move. The frustrating thing about cerebellar dysfunction is you could have perfectly normal strength and perfectly normal sensation and still have great difficulty walking because you can't control how much you're moving. So the big tremors that we see with cerebellar dysfunction can affect the arms, the leg, the trunk, and they can really affect walking ability. So one of the devices out there, oops, I already covered that. One of the devices out there that we use to help treat cerebellar dysfunction is something called deep brain stimulation. You could argue that this is a little bit more geared towards upper extremity function than lower extremity function, but I've seen it work for a whole side of the body. So the idea with deep brain stimulation is you're going to place this sort of little pacemaker somewhere under around the area of the collarbone. You have a micro electrode that sort of runs under the skin, and it's going to drop through a small hole in the skull into a part of the brain called the thalamus. The thalamus is a relay station from the cerebellum. And so by putting that electrode in just the right place, you can actually override the tremor. If you look at YouTube videos of this surgery, it's fairly amazing. This surgery is done while the person is awake. So when you think about what's painful in the above the neck, really it's the skin, a little bit of the bone, the muscle itself. The brain itself is incapable of sensing pain itself. It interprets pain from other parts of the body, but you can touch the brain and poke on it, and it's not painful. So during the surgery, after local anesthesia is given, there's a small hole put into the skull. So if you're trying to control, say, cerebellar dysfunction on the left side of the body, you're going to do the right side thalamus. And so small hole, that micro electrode is dropped down into the thalamus while the person is awake, because you want that person doing activities with the affected limb so that you know when you've got the electrode in the right place. And so when the electrode is in the right spot, you should see that tremor, that sort of abnormal movement quiet down pretty dramatically. Typically, these are only put on one side or the other. Occasionally, if there's severe cerebellar dysfunction affecting both sides, I have seen them done bilaterally. We have an individual who has bilateral deep brain stimulators, and it's worked very, very well for that person. What about robotic devices? Do they play any role in the MS world? So there are some studies going on with various exoskeletons. So these are robotic devices that have a small motor somewhere, a motor backpack on this person's lower back here. And then you have this exoskeleton going down the extremities. This is usually going to be used for people with severe weakness in both legs. And it's going to, again, just sort of give them that rigid support, and the motor is going to drive that walking. This is one of the devices that is being looked at, the Cyberdyne HAL system. Here, we've done some research with this device, the Keeogo Exoskeleton, and with this Indego Exoskeleton. So this gentleman is actually one of our employees here. He's had a spinal cord injury as a result of a motorcycle accident, and he was one of our study participants in the Indego system. So this backpack, motorized backpack, is on his back. One of the challenges with these systems has been how easy are they to get on and off, and how heavy is that motor on the back. Early on with some of these robotic exoskeletons, the motor was way too heavy, and so Lord help the person if they fell over. They were literally like a turtle on the ground. They just couldn't go anywhere. But this Indego system's pretty lightweight. I want to say that motor's about 20 pounds, so they are getting better. Yeah, I put this under robotics. It's not quite the traditional robotic, but this is research that's near and dear to our hearts here. Dr. Deborah Backus is our head of research here at Shepherd Center, and has done 2 studies on the FES bike, functional electrical stimulation. So the idea with an FES bike is the person is in some type of sort of hand crank or foot crank bicycle. We have systems set up like this where the person can come up in the wheelchair. You can also use this on a traditional exercise bike. And then there are electrodes put in different major muscle groups on both legs. And then there's actually a motor in this system as well. So the person's going to start biking, start pedaling. When they start fatiguing, that unit is going to sense that they're fatiguing. And it's going, those electrodes on the major muscle groups are going to start firing their muscles for them. This motor may come in and assist a little bit as well. So it allows the person to continue using those muscles long past when they would have normally been able to do it. Normally in a person with MS, when you hit that wall, you're done. Well, this lets you go past that wall without the brain or spinal cord actually saying so. The system is telling you to do it. So the question with the FES bike that researchers have looked at is, does using this type of device in a training session translate into better endurance and better walking in the real world? And in 2 studies we've done here at Shepherd Center, it translated into better walking ability. So this is something that we offer. I know other MS centers offer this as an exercise option to hopefully improve walking even when the person's not using that device. So this is brand new as well. This is called the PoNs unit. It is a neural stimulator. A lot of the research for this device came from the Department of Defense. This is being looked at in individuals who've had spinal cord injuries. A lot of the original research was done in soldiers who had had spinal cord or brain injuries due to IED explosions in Iraq or Afghanistan. This is what the device looks like. It's kind of a little almost headset device. This goes actually under the tongue. And so the idea is, so this little pad is under the tongue. It is a neural modulator stimulator. The idea is by sending signals through the cranial nerves to the brainstem, can we actually promote sort of neural rerouting, if you will? So if you have an area of damage in the brain or spinal cord, an area of demyelination that is impairing your walking, what if we could just form new pathways and reroute around this? So what studies have suggested is if you use this device during physical therapy sessions, that it seems to promote this sort of neural rerouting, and that there are more functional gains when you use this device than we would see with just physical therapy by itself. Again, it's new. The studies that got it FDA approved were small. And they were done in a mixture of people, MS, traumatic spinal cord injury, brain injury, stroke. So we're right now here at Shepherd Center, we're in the process of having our therapists get trained in using this device, and we hopefully we'll be up and running in the next couple of months here with this sort of technology. I wanted to talk for just a minute about one of the most common forms of technology that a lot of people with MS use, and that's just power mobility. So power mobility, you can really divide into either scooters or power wheelchairs. And it's hard to know sometimes which is the right piece of equipment for you. I will say that if you work with a seating clinic, so a lot of comprehensive MS centers have a seating clinic. These are physical therapists that you go to. They're not selling you anything. They are your advocate to the vendor. So they're going to help determine what is the right piece of equipment for you. A lot of times we have individuals with MS who really want a scooter. They go to the seating clinic and they're told, no, you really don't want a scooter, you really want a power chair. There you will get a sense that a lot of physical therapists and seating clinics are kind of biased against scooters, and you're not imagining it. They are sometimes biased against scooters. And it's not that scooters are a bad thing. They can be wonderful in the right individual. But why would therapists or seating clinics tend to prefer a power chair over a scooter? A lot of reasons. There's very little lateral support in a scooter. So if you've got core weakness, you don't have great coordination of your core, maybe you're at risk for falling out of this. That may be one reason why the therapist may actually prefer the power chair to the scooter. One of the other challenges with scooters is that a scooter is a scooter is a scooter. They cannot be modified, whereas a power chair can be modified. They can be custom fitted. You can add stuff to it. You can take stuff away from it. So in general, you'll see the therapist may be trying to steer you in this direction. Again, scooter is perfectly appropriate for some individuals. It really depends upon what you need. If you go on the Medicare website, you can actually look up what the Medicare requirements are to qualify for either of these pieces of equipment. They do have very specific rules on what they want to see to be eligible for one of these. It's interesting. I couldn't find it on the Medicare site, but it's always been our understanding that whichever piece of equipment you get, you're going to have that piece of equipment for 5 years. So we like to make sure that we get it right up front, that we get the right piece of equipment. I think there can be exceptions. Obviously, if your physical needs change drastically, let's say that you're perfectly appropriate for a scooter this year, and you have a big MS relapse or something happens and your physical needs drastically change a year, 2 years from now, I think we can make an argument medically to go to a power chair at that point. But just in general, that 5-year rule is what we kind of hold on to. If you have a chair, you've been in the same power chair for 6 years, and you're requiring a lot of repairs on that chair, it's spending a lot of time in the shop, that's the point at which we probably need to start thinking about getting you a new chair. Why is Medicare so strict, on these pieces of equipment? They're expensive. We see power chairs that can cost over $20,000. There has been fraud and abuse, unfortunately, on the part of vendors out there in the real world, and so it makes Medicare really clamp down and make sure that we're giving the right piece of equipment to the right individual. I think I'm going to turn it over to Chris. He had some comments on some programming from the MS Focus folks, and then we'll go to questions and your thoughts.
Thank you so much. I appreciate that. Before we open it up for questions, I want to take this moment to let everybody know that MS Focus sponsors an assistive technology program. It may help locate, partially fund, or provide full funding for one of a wide range of devices. You can find out more information from our website at msfocus.org. Go under the Get Help tab in the Grants and Programs page, and you will find the link to the Assistive Technology Program. Now we're ready for questions. If you have a question or a comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you choose. or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you and then you will be able to unmute to ask your question. And let's start with a question from let's start with a question from the chat. And actually, this is this first is less of a question, more of a comment from Carolyn. I had a really bad experience with the one-time dose trial of baclofen.
So, when we think about baclofen, and I'm assuming she had the spinal tap, the intrathecal baclofen, that's why we do the trials, because we want to know if you're that individual who's not going to have a good experience. Sometimes baclofen intrathecally works more than we want it to. So it can make, if you get too much baclofen, you get weak. And so we may go from someone who's got really tight legs with a lot of extensor tone to someone who's just a rag doll. And that's not what we're shooting for either. So yeah, I mean, when they do the trials, they try to do a small dose to see if it's going to do something good, something in the middle of the road, or hopefully not something bad, but it does occasionally happen that people have a negative response. And then again, that's why the trial is done.
We have a question on the Q&A, this one from Nicolette. Any information on the Evo Walk or the new WalkAide 2.0?
I have not. I know that both of those are out there. I don't know if they've changed that sort of parameter where they're set at a certain level. I mean, hopefully by the time we do this next time in a couple of months, we'll have some updates on that. I think it's very cool that we're seeing a lot of new technology. I mean, the neural sleeve from Cionic, the fact that WalkAide is, up in their game. I'd love to see both WalkAide and Bioness have a competing device. These are not inexpensive pieces of equipment. I think the more competition there is, maybe the more likely it is that prices stay the same or maybe shock us and come down. Yeah, I think that'd be great if WalkAide has changed their parameters, but I don't know that for a fact yet. Hopefully next time when we speak, we will have had a chance to demo that unit.
We have a question from Robert in the chat. Will 2 ITB be okay for 1.5 hours in the MRI? He's got in parentheses brain, cervical, T-spine.
So read that again one more time.
Will 2 ITB be okay for 1.5 hours in the MRI?
Yeah, so in general, yes. So, a lot of times when we're doing MRIs, it's not unusual that people will get brain and cervical or brain, cervical, and thoracic, and you're in there for a bit. So the pumps, generally the intrathecal baclofen pumps, should be fine in the machine. So it's not really a function of the duration of the MRI. The magnetic field may, 1.5 versus a 3T may play some role. But again, the most important thing is that regardless of the length of the MRI or the strength of the magnet that you're in, is that you get that pump interrogated. And anyone working with baclofen pumps is going to know how to do that. So it's just a simple matter of, someone using that external device, making sure the pump is still set at what it's supposed to be set at, and then it's turned back on after the MRI.
Let me take a moment here to remind people that if you have a question or comment, you can ask it using the Q&A button in the app, which allows you to send your question anonymously if you choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you and then you will be able to unmute to ask your question. And I have an anonymous attendee here in the Q&A. He asks, "Hi, Dr. T. It's great to see you again. Sorry I joined late. Are there any devices on use Are there any devices to use on someone who has a history of seizures, someone with CRPS and MS?
So I'm just thinking of all the devices we've gone through, if there would be a contraindication for someone with epilepsy. I don't think that any of those would be contraindicated with epilepsy. The only one I don't know for sure is the PoNs device. Again, I'll stay tuned on that one, just because that's closer to your central nervous system and it is electrical stimulation. That one could be a concern with someone with epilepsy, but I don't. We'll have to when we do the demo units, we'll have to see if that's the case. Other than that, any of the peripheral devices, your Bioness, your WalkAides, intrathecal baclofen, deep brain stimulation, any of those would be okay. The regional pain syndromes, that could be challenging. So if you have hypersensitivity to touch, reflex sympathetic dystrophy, a complex regional pain syndrome in a leg, I could see that potentially making a Bioness device a little bit challenging. Again, I think the bottom line, it wouldn't be dangerous. It could just be uncomfortable. So I think it's just going to be a matter of putting the device on and seeing if it's tolerable and functional for you.
We have a caller. I see a call here at 6
Hi,
1.
my name is Steve.
There we go. Please ask your question.
Yeah, I just would like for you to repeat what you said about the FDA approval with some neuro something. I didn't get it all. I'm sorry.
Yeah. So the neural sleeve is from a company. I'll go back here for a second. We'll put that back up. So Cionic is the company out of San Francisco that makes this newly cleared device, the neural sleeve, which is that black neoprene device on the person's leg, 4-foot drop. When we say that something is FDA cleared, that's different from FDA authorized. So FDA authorization usually means they're making some comment on how effective the therapy is in addition to how safe it is. FDA clearance really means they're just saying it's safe. They're really not making a big comment for or against in terms of effectiveness. And the reason they really are probably not making a big comment on effectiveness is because it was a small trial. It was 70 individuals, but the results in those 70 individuals did look impressive. Again, 143% improvement in foot drops. So yeah, we look forward to seeing this in the real world, and hopefully it gives us one more great tool to work with for foot drop.
Perfect. Thank you.
Absolutely. You're welcome.
And thank you for calling. We have another question from the chat. This one from Jody. Is there any way to get the Bioness covered by Medicare?
Yeah, so the frustrating thing with the Bioness is, if you do the base unit and the upper cuff, it's about $8,000. It is FDA approved for multiple sclerosis. Why we fight and fight and fight with insurance companies, including Medicare, over this is a mystery. I'll be very honest. We've probably lost more of those battles than we have won. So what we've done here at Shepherd Center is we, through a very gracious donor, were able to establish a fund. And so if an individual with MS trials one of these units and it works great, we will apply for insurance. If insurance denies it, we'll look at what that individual, if they're able to contribute something, great. If they're able to contribute nothing, no problem. We will pick up the cost either partially or in whole for the cost of these units for individuals with MS. It wouldn't surprise me if other MS centers might have something like this. I don't want to speak for Chris. You might be able to speak for this. In terms of the assistive technology fund, I know that's a large chunk of money. So with the grants through MS Focus, do those cap out at a certain amount for the assistive technology?
That I do not know. Actually, to be quite honest, Casey could probably answer this question better than I could. But my guess is that there's a procedure for that.
And what I would suggest
There
too,
is a cap. There is a cap to the program. I don't know off the top of my head what it is. And I'm not entirely sure whether FES devices are covered. But I would suggest that anybody who's in the process give our support services coordinators a call, because they are going to be able to give you a definitive answer and possibly tell you if there is any other programs for assistance out there that could contribute.
and I would suggest to the caller too, you know, if you're not somewhere where your healthcare team is able to fund the device completely, you may have to put together different little pots of money. You may have to look at MS Focus. You may have to go to National MS Society, get a little bit from them. I mean, I've had a patient years ago before we set up our own fund who really needed bilateral Bioness units, and she did a GoFundMe with their church contributing quite a bit through that, and was able to get them through that. So yeah, I hate that the financial part would be a barrier to someone using something that they need medically, but I think if you're creative enough, and if you've trialed it and it works, I wouldn't give up.
We have another Bioness question from someone from an anonymous individual in the question and answer queue. Will the Bioness cuff get smaller? Do you know what kind of research they are working on?
So, I mean, they've certainly modified it a lot. You think, with what we're using now, the L300 GO, we've gotten rid of that clip on the shoe. I don't know if the device itself will get any smaller than that. There is a pediatric one. So we had this come up with one of our individuals here recently. It was a woman who's very petite, and the adult cuff was just way too big. And so we ended up using a pediatric size. So there are smaller versions that are meant for kids that some small adults may use. I think in terms of just the standard adult size, looking at that picture, do I think that that's likely to get much smaller? I would bet not, just because I think the problem, if you get it much smaller, you're going to have it start moving around more, and not staying in place. So my bet would be it's probably going to stay about that size.
All right, we have we have Kent. Feel free to ask your question, Kent. Hold on just a second. Kent, you should have gotten a request to unmute. There you go. Hi, Kent, you got a question?
Yes, I'm seeing a chiropractor, and it's helping some with walking. What about chiropractic treatment?
Yeah, I think when you think about walking and how it can be affected in MS, there are a lot of different factors that go into walking dysfunction. If some of your gait dysfunction is neck, low back pain, poor body mechanics, I think chiropractic is certainly reasonable to try out. I think of chiropractors as just being part of the bigger comprehensive team, not the other, that we should shun them, but being part of the team. The only caution that I would throw out is if you're looking at chiropractic care for neck issues, we just don't like to see the old school chiropractic where they're really doing the vigorous, snappy adjustments. That's pretty rare. I don't think I've seen that in a while. I mean, modern chiropractic care, I think, integrates pretty well with the rest of the big MS team. So yeah, I think it's certainly a tool worth looking at.
That was my question.
Yeah.
Thank you very much. Thank you very much, Ken. Just a reminder, just want to take a moment to remind people that if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you are on the phone. I will call on you and then you'll be able to unmute to ask your question. And so for our next question, from our chat queue here, this is from Tina. I currently use a hip flexion assist device from Becker, but it hurts my back. Do you think any of these devices help in place of this?
So one of the biggest challenges I think we have, so we talked about, all these devices that help with ankle dorsiflexor weakness, so the foot drop, but we said that people's hip flexors are weak also. No one has come up with a wonderful device to help with hip flexor weakness. So the device that you're using is, one of the things that's out there. I don't think that it's likely that we'll ever have an external electrical stimulator device for the hip flexors, because that nerve to fire the hip flexors is buried pretty deep in your pelvis. To have an external device that would stimulate that nerve, it would be extremely uncomfortable. It's going to deliver an electric shock that probably would not be tolerable. There was a tease back around 2004, 2005 about surgically implantable Bioness. So these would be little surgically implantable nerve stimulators that you would put in over different motor points. And then you would carry sort of a pager unit that has the motor programmed to fire those muscles. It seems to have kind of gone dark. That I've done literature searches. I just did one yesterday on PubMed to see if anything's been published since 2005, and nothing has been published. So I don't know if they ran into technical barriers that just prevented them from doing, because that would have been a great idea for hip flexor weakness. If you're, the device that you're using, if you've not, shown that to a physical therapist and had them work some with you, I would certainly encourage that, just to see if they've got any suggestions. We've mentioned that walking is complex, and when you throw off one movement, it's going to put more stress on something else, either your knee, your hip, or your lower back. And so if you've not had a physical therapist watch you walking with that to see if they might fine tune it, I would definitely encourage that. I don't know that there's a better device right now, though, for that hip flexor weakness.
We have another question from the question and answer queue, this one from Jody. I'm currently using a rollator for long distance walking. I have right foot drop. How or when do you know when it's time to make the switch to scooter or motorized chair? Also, I know scooters can break down to fit into the trunk. What about electric chairs?
Yeah, so all great questions. And so I would, again, if you've not seen a physical therapist, I would definitely make sure you see one to address that foot drop. So if you're using a roller walker and you have foot drop, would you benefit from a rollator walker and something to address the foot drop at the same time, whether that's the Bioness, the neural sleeve, ankle foot orthotic, the Sabo device, something that would, again, in that case study that that we showed here, this lady's using a walker and something for her foot drop. When she switched to something that was more appropriate for her foot drop, her walking speed doubled. In a perfect world, you'd have lots of pieces of equipment that you could choose from based upon what your activity was going to be that day. So you're going for a longer trip to the mall, and you're going to be at risk for fatiguing. So maybe that's the day you take the scooter. And I think sometimes we're able to pull that off. I will say usually you're going to be limited to one piece of power equipment, either the chair or the scooter. If you're thinking you might benefit from both a scooter in certain situations and a power chair for your daily use, I would definitely have insurance work on the power chair, because that's going to be your more expensive piece of equipment. And then maybe look at a scooter through some other funding mechanism, whether it's you pay out of pocket or pick up one on the used market for less expense. Scooters are generally more mobile. There are some small ones out there that can be folded up and put into the trunk. Pretty rare that you're going to see a true power chair that you could do that with. There are some motors that can be attached to a manual chair that are a bit more mobile, but I don't usually think of those as a great long-term option for most people with MS. I think if you're going to go with a power chair, rather than sticking a motor on a manual chair, you're probably better off going with a true power chair. If you work with a seating clinic, one of the questions that they're going to look at is not only what's the best piece of equipment to fit your activities of daily living, but does that piece of equipment fit into your house? Does it fit into your doorways? Do you have stairs that you need to get up? And how do you transport it? So a good seating clinic is going to look at all of that. They're going, if your car needs to be modified with a lift on the back of it so that you can get a power chair or a scooter somewhere, they should look at that big picture. It doesn't help if we give you a 300-pound power chair and you have no way of getting it to your doctor's appointments or to your physical therapy appointments. We need to look at the big picture.
Just a couple more questions here before we close. First, we have a question by Desiree from Facebook. What is the difference between Bioness and the sleeve? Does it support more?
Yeah, so at this point, I would say that functionally they're supposed to do the same thing. They're both supposed to stimulate a nerve and make the nerve work again, and therefore make the muscle work again. Again, we've not gotten our hands on the neural sleeve yet, so I can't make any comments on it in real life. Again, we hope to have the demo done here in the next month for sure, and then they're commercially available in the fall. So yeah, I'm praying it works out beautifully, and it's just one more great tool. Again, they're designed to attack the same problem. They're designed to stimulate the peroneal nerve or the nerve to the knee flexors and make that muscle work again when you can't get a signal from brain to spinal cord to nerve to muscle.
We have an anonymous question in the Q&A queue. Any suggestions for an electrostimulator device if you need to wear a compression hose?
Yeah, that gets challenging because you can't use the stimulator over the compression hose because you're not going to get enough stimulation. Yeah, you probably are going to have to work with the garment manufacturer, the compression garment manufacturer, and you may actually have to do something. If you need a compression garment that goes above the knee, you're probably going to have two garments, one that's split, one that goes above the knee, put your stimulation device on, and then something goes below the knee. Yeah, that's we've seen that come up. That makes life a little trickier.
One more question. This one is from Linda. Can clonus be due to circulation issues, or is it always due to nerve tendon issues?
Yeah, clonus is always neurological. It's never vascular. So if you got bouncy leg from a hyperactive deep tendon reflex with spasticity, that is neurological. That's coming from the brain or spinal cord, not vascular.
All right, that brings us to the end of our time. If you missed any of this conference, it has been recorded and will be available through MS Focus Facebook and our YouTube channel. Reply to your registration email for information on how to access recordings, or sign up for our newsletter to learn about upcoming events. Speaking of which, our next teleconference will be at 3:30 p.m. Eastern, Wednesday, May 18th, when Dr. Teresham Gang discusses MS drugs in the pipeline and the newest research. Register at msfocus/GYANG 0522 And our sincere thanks to our sponsors, to all of our attendees for your participation, and especially to Dr. Thrower. Thank you so much for your time, for the time you spent to prepare and share this information with us.
Thank you. I hope everyone has a wonderful afternoon.